It's my pleasure to welcome this afternoon's lunchtime plenary speaker, Michael Hallsworth. Michael is Principal Advisor and Head of Health and Tax at the Behavioural Insight team in the UK. He'll tell us quite a bit more about this group, but basically it started out as the world's first government institution dedicated to the application of behavioral science. As of February of this year, it's become a consulting firm that's owned by the employees, the UK government, and an organization called Nesta. And Michael will be telling us a bit more about the group's work. Take it away, thanks.
Thank you, and thank you very much for inviting me here to talk to you. It's an absolute pleasure to be here and contribute to this conference. First, it's important for me to explain what the Behavioural Insights team is and what it was. We were originally set up in 2010 when the current administration made an explicit commitment in its coalition agreement to apply insights from behavioural economics and social psychology to policy. It's fair to say that the reaction from the civil service was pretty sceptical, which is quite understandable. It could easily have been seen as a case of government buying the hype and adopting the latest fashionable idea at the expense of perhaps more important issues. And there was genuine doubt about how any of this would play out in practice. Therefore, the team was deliberately small, just 8 people, and had a strong commitment to evaluating its work robustly. This focus on evaluation meant that we were able to show that the changes we introduced had made a difference to important policy areas. Sometimes there was no effect on outcomes, but overall people began to take notice. We began to see more and more departments approaching us for advice. In terms of health, we now work with the Department of Health, the National Health Service, and Public Health England. In order to meet this increased demand, a decision was taken essentially to separate the team from government. So we had greater ability to hire people. So now we're a social purpose company, partly owned by government, partly owned by the employees, and partly owned by an innovation charity. This means what I say today shouldn't be taken as representing the views of the UK government. So what does the team do? Basically, we try to incorporate empirical findings about how people actually behave, and thus what really influences behaviour, into policymaking. We've been colloquially referred to as the nudge unit, and indeed that's fair in many ways. We're absolutely privileged to have Richard Thaler advising us, and we do apply findings from behavioural economics to a policy context. However, we're not called the nudge unit, and that's important. The main reason is we don't start with the question, how can we nudge? But rather, we've got a policy problem here. What do we know? What evidence can we bring to bear? We try to understand the policy issue in the round and assess all the policy options. We take this fuller view because the fundamental truth is that most policy intends to influence behaviour, from murder laws to tax breaks to drinking water standards and guidelines for financial products. So we're thinking about behaviour when considering the main existing tools of government, such as regulation, incentives, and information. Behavioural insights can therefore allow us to enhance or reassess the use of more traditional policy options, as well as offering new options to sit alongside those. However, I think this point often gets lost. At its worst, there can be a tendency to talk as if policymakers guide do normal policy or do something behavioural, a nudge, for example, as if these are two totally separate things. Most policies influence behaviour, and therefore the behavioural sciences have something to say about most policies. Therefore, I'd argue it's more important to understand behavioural insights as a lens through which to see all government action, rather than simply offering new tools in the policy toolbox, although they do that as well. This wider perspective allows us to see that there are many different ways of applying behavioural insights that avoid many of the objections that have been raised. I'm going to suggest 7 of these options in a second, and quite rightly, these are the ones we've put into practice. But before I talk about those, I just want to run through what I'm calling the technocratic defense of applying behavioral insights. This basically says government has decided to address certain policy issues, and it should do that as effectively as possible, applying the best available evidence. If there's new evidence about how people will actually react, then this should be used to enhance policies. When regulating, structure the incentives so they loom large. When writing a letter, make it as clear and well-structured as possible. So some people would say you have a duty, even a moral duty, to maximize effectiveness in this way, since it means you're spending limited resources wisely. In the UK Civil Service Code requires officials to make decisions and provide advice on rigorous analysis of the evidence. That's the quote. Suppose you were a health policymaker looking to, say, reduce the number of disability-adjusted life years as cost-effectively as possible. Then you're likely to start by looking at something like this. So what's striking is the proportion of disease coming from behavioural causes. I've highlighted the ones you might be pretty confident about, and you're likely to look at that and think, well, rigorous analysis of the evidence, in this case, means understanding factors that influence behaviour and how to change it. While structural factors like social determinants play a big role, it's noticeable that only around 4% of total UK health research spending actually considers psychological or behavioural factors. In the UK, we're spending 20 times more on treating smoking-related illnesses than on trying to get people to stop. If you can't see the graph, I realize it's quite far away. It just lists the kind of behavioural factors you might be involved with some of these diseases. So you've got things like dietary risks, smoking, high body mass index, alcohol use, physical inactivity, drug use. Those are the ones I highlighted. So it seems that a diligent policymaker should be obtaining or commissioning the best empirical evidence on influence and behaviour and applying it. But of course, this is only a partial defence. It leaves many philosophical questions unanswered. That's why you're having the conference. It assumes that government has already got involved in a particular area, for example. But I don't think this argument can be dismissed or should be dismissed entirely. Look at the graph. I'm now going to talk about some ways that behavioural insights have been applied in practice. Only a couple of them come close to nudges, as often discussed. So applying behavioural analysis may show that the best option is to stop or revise an existing action government's doing that may be unintentionally influencing behaviour. Maybe decide not to try and change behaviour, but shape policy around that behaviour. Maybe prevent a counterproductive policy from being introduced in the first place. It may address the flaws in policymaking process itself. It may be about influencing healthcare providers, not patients. It may be about helping people to find strategies, new strategies for taking personal responsibility for their health. And it may be around preventing harm to others in a health context. Now, if you look at who you're talking about influencing here, it may be that in the first three, it's actually no one. The second group, you're talking about organizations and professionals. And the last group, you are talking about health system users. So first, applying behavioral science can lead government to reassess the impact of its current actions. The point here is that government may be influencing behavior even if it's not intending to. Policies may be having unnoticed effects. Interventions that seem to make sense may actually be backfiring. Perhaps the best example here is the design work that's been done in accident and emergency departments in the UK. So violence and aggression against hospital staff costs the National Health Service at least £70 million a year on the official estimate because of staff absences and additional security. It turns out that the frustrating bad design of accident and emergency makes a big contribution to this. Poor signage, poor line of sight, lack of visual progress through the system. And these may have come about through lack of understanding of the effects of design on behavior, through carelessness, through failure to adopt the perspective of the patient. So when the UK Design Council ran a project to identify and address these issues, they tested them in 2 hospitals. They found they applied design principles to make it clearer what was happening, to basically make it a much more pleasant and understandable experience. They found a reduction in aggressive behaviour and reported frustration. Previous project doing the same thing found a reduction in actual violent incidents towards staff. So we're talking here about a case of unintentional harm that I'd argue it'd be unethical not to address. And I'd argue that this perspective leads to less complacent government, gets away from the idea that, oh, if we're only influencing people if we're trying to influence people. That's not the case. Let's stay with the topic of hospital emergency departments for the second option. The UK is currently dealing with the issue of people going to emergency departments for ailments that could be treated elsewhere. And that's causing significant problems. I believe that something similar may be happening in the US, actually. So if you take the time to understand the situation people face, this can seem like reasonable behaviour from the individual's point of view. You know, if you're looking at what's available, you might actually go to A&E because it's, you know what you're going to get. So what could you do here? You could nudge people by informing them of alternative options when or just after they're making a necessary visit. So behavioural insights there is the timing and the salience. Here's what else is available. But your behavioural analysis may actually show that it's very difficult to change behaviour here, in this instance. Since people are using a heuristic, go to hospital, go to A&E, that is working for them. So your policy may actually be to adapt the service so people don't have to change their behaviour, perhaps by co-locating the emergency and non-emergency care. People can keep doing what they're doing without causing the policy problem. It's a picture of a hospital. I meant to click through to that. Third, behavioural analysis may prevent the introduction of a policy by showing it may have a counterproductive effect on behavioural or policy priorities. So the team's actually highlighted the potential large impact of electronic cigarettes to save lives through substitution, and there's some data that's coming out that is the case. So this is based on the behavioural evidence that habits are often successfully amended if cues and routines, so I see something and I react a certain way, are kept the same, but the target behaviour is changed. So you're doing pretty much everything the same in terms of smoking, but you're not getting the harm. Therefore, we've argued against measures that may significantly affect take-up, like unnecessarily strong regulation. Now, of course, we need to monitor this situation, see how it develops, and if it looks like electronic cigarettes are leading to more smoking, look at harder measures. But we don't have that evidence yet. And a behavioural analysis suggests that we may cause harm by starting with hard regulation. So, as these first 3 examples show, applying behavioural insights does not necessitate new government action, but neither does it rule out harder measures. It's more concerned with improving government action, whatever that may actually be. And that includes my 4th point, which is improving the way policy is made. As many others have pointed out, government itself is affected by the biases that behavioural theory highlights. Policymakers don't have some special immunity, and we agree with that entirely. But we also see this is a strong reason for extending nudging to government itself, rather than doing away with it altogether. Take availability bias. So there are many examples where a policy has come about from a single story or observation that a policymaker encounters, even though it may not be the best course of action, or even an effective one. Confirmation bias takes hold, and evidence is then sought out to confirm this initial impression. It's said that the policy that hospital workers should be bare below the elbow in the UK, it was controversial at the time, came about from a specific conversation or hospital visit. We can find ways of adjusting policymaking processes to ensure that system 2, if you like, has considered a policy fully. And 5th, we can talk about influencing actors in the healthcare system. In 2000, the Institute of Medicine found that in the US, 100,000 deaths a year were coming from avoidable medical errors. In the UK, half of hospital admissions suffer prescribing errors when paper-based charts are used. The concern is that these charts hinder clear communication between professionals. It can be difficult to distinguish between milligrams and micrograms when written out by hand in a hurry. So a study by Imperial College London, funded by the Behavioural Insights team, tried to reduce these errors by redesigning the charts. This is the redesigned chart. As you can see, the milligram-microgram problem is addressed by creating options I just realised there's a pointer, sorry. It's a bit embarrassing. Options, milligram, microgram, you just have to circle. So in simulation testing, in the paper mentioned there, the new chart significantly improved correct dose entries. So you can see here, on the left you've got in the blue, the existing chart, in orange, the revised chart. Dose entered correctly was pretty high. Actually, that's probably higher than it would be in reality. Contact numbers and frequency of medications, massive improvement. So improvements like these are likely to mean fewer medical errors and better patient outcomes for little cost and no additional burden. And then, of course, we may try to influence health system users. But again, there are ways of doing this that don't impede autonomy, learning, or flourishing. In fact, we think behavioural science can be used in the service of these things. Take obesity, for example. There's much evidence that our eating is mindless. We eat what is put in front of us, almost regardless of the size. Now, I've put here a chart from a very interesting article in Public Health and Nutrition, and this basically shows that we're serving, both restaurants and caterers are serving us more food, and we're serving ourselves more food over time. Now, one response to this, the fact that we're serving ourselves more food and we're eating it, because essentially when something's put in front of us, we eat it. One response to this may be to change the choice environment, to reduce plate sizes and so on. But another legitimate use of behavioural science is to tell people about how eating works, so what I've just talked about, the automatic responses around eating, and then help people develop, adopt pragmatic and effective rules of thumb that address this tendency. For example, if we become more aware that we usually overestimate our ability to resist temptation, and there's good evidence we do, we can use simple strategies to ensure in advance that we won't be exposed to tempting food at a particular time. So the point of these strategies is not to try and change the hardwired aspects of how we eat, because that will fail. Rather, the idea is to allow us to bring them under control by using System 2 to manage the effects of System 1. And this is exactly what Brian Wansink's Mindless Eating Challenge has been doing in the US. Adopting rules of thumb you can apply in your life that take into account what we know about behaviour. And similarly, Behavioural Insights would point towards the massive literature on creating implementation intentions. Golwitz's ideas, absolutely loads of supporting evidence around this. And that basically means that people are more likely to follow through on the goals if they make particular plans about what's going to happen and work out how to deal with that. And this isn't about reducing autonomy, it's about giving it more ways of being more effective. So, I come on to another issue on the list. So Nudge focuses mainly on the book Nudge, the idea Nudge, focuses mainly on helping people fulfill their intentions. We've been talking a lot about that. But from a policymaker's point of view, there are many instances where doing so creates harms to others, other people affected. And it's generally accepted that government involvement is more legitimate in those situations than if you're purely considering harms to self. John Stuart Mill thought this. Economists often refer to negative externalities. There was a reference to libertarian welfarism earlier today. But note that the line between harms to self and harms to others is quite blurry. So not turning up to your hospital outpatient appointment harms others by creating unnecessary delays and waste in the system. but it also may harm your own health because you're not getting the care that you may need. Now, this particular issue is a problem for policymakers in the UK. 1 in 10 hospital outpatient appointments is missed. That's around 6 million a year. And there have been various ways to try and reduce this. A lot of hospitals have adopted text reminders, SMS reminders, so a few days before you get an SMS to say, remember your appointment's coming up. Now, we know that works. There's good evidence. Cochrane Review says that works. That's fine. But what we don't know is whether the wording, the message in the text message, makes a difference. And this is what we wanted to look at. So we actually ran a trial to do this in a London hospital. And we tried 4 different wordings. So we took the existing message, which was something along the lines of, this is the date and time of your appointment. If you can't make it, please phone the number on your appointment letter. What if you don't have your appointment letter to hand? Okay, so there's an obvious potential problem there. So what we did was we amended this by putting in the number you had to phone into the text message. So you reduce the friction costs. You make it easier to cancel. We also put in the message pointing out, as I just did, that 9 out of 10 people do turn up to their appointment, or they cancel. Because the other thing is, fine, if you cancel, then there's no problem either. What we just don't want is people turning up, having not turning up, having said nothing. So the fact that norms is that most other people do turn up or let us know. And then the cost was the actual cost of a missed appointment, this particular missed appointment. So it was something like this appointment cost £160 to the NHS, which is what it does cost. So if you look at the proportion of missed appointments for the basic control, it was 11.7. For putting the number in had no effect, really. So that didn't work, which is surprising, you might think. Social norms didn't actually work either. But out the costs, reduced the number of missed appointments by about a third. Now, there's no additional cost here. The text message is the same length. Or people are doing what they really should do anyway. And it's a small prompt. And we found that if you did this for over a year in this hospital, it would reduce missed appointments by 41,000. Now, so this is a case of behaviour spilling over and creating harms to others. But I think we would also agree it's justified to impose some small costs on people to prevent harms elsewhere, even if they haven't caused the harms themselves. So if you look at this graph, what this shows is that essentially shows the number of deaths from accidental or deliberate poisoning, suicide or accidents from paracetamol in the UK over time. So we're on upward, pointed doesn't actually work, so I'm going to use the power of words here. The trend is going up over time, and then you've got the vertical line, which is when a law was introduced which said, which limited the size of paracetamol packs you could buy, I think in pharmacies and indeed in other shops, took it down. And I think there was also something around that you couldn't buy a bottle, you had to actually press out the paracetamol individually. Now, you can see from this graph that the number of deaths has gone down quite significantly. Very impressive. This is an interrupted time series analysis. They calculate in this study in the British Medical Journal that was worth around 800 people not dying over the decade. I think we'd agree that there are benefits to this policy. It doesn't reduce choice. You can still obtain the same amount of paracetamol. Are we really disrespecting people's true intentions to commit suicide? Perhaps, but given that it seems to hinge on the effort of additional effort of punching out pills or going to another shop, you may question that. And of course, there may be spillovers we can't see. People may be finding other ways to kill themselves. But on this evidence, those alternative options have got to be pretty easy as well. In fact, there's evidence that people don't generally find other ways to kill themselves. It's about, is it immediately available to me? And that's been shown when they changed the coal gas to a different type of gas in the 60s, Number of suicides went down greatly. So here's the question. Is this different from the big gulp ban? One stops people buying large sodas in one go to reduce the likelihood of obesity. The other stops people buying large painkillers in one go to stop the likelihood of suicide and accidental poisoning. In both cases, you still get the product. You still can get the product. I'd say the harms involved and the strength of the evidence make them quite different. I think most people would agree they seem different in important ways. But these are starting to get into more technical points. If you deal purely in abstractions, then you could argue that they operate on the same principles. And by the way, I'm not advocating the soda ban. I'm using it as a point of contrast here, that's all. A point about abstractions versus a case-by-case analysis. Case-by-case is a better way of assessing these things, and that's how policymakers actually deal with them. I absolutely don't think we can dismiss options out of hand. I think nudging behavioural insights should be part of the policy mix. So taking a broader view, looking at this as a lens through which we see government action, shows there are ways of using behavioural insights which are not about changing behaviour, that are directed at those with professional responsibility and that can help strengthen autonomy, not reduce it. And furthermore, when dealing with the policy world, there are a set of checks, balances, and safeguards. Most obviously, ministers in the UK are democratically elected and they're answerable to the public. Second, as I've mentioned, we try wherever possible to test our ideas rigorously through randomized control trials. We do this simply because, well, we don't know what the effect will be in practice. Behavior is complex and we can't be complacent. All trials involving the National Health Service have to be approved by an ethics board and put on a trials register, and that's exactly what we do. So the fact we trial things in health provides an additional safeguard. Moreover, we publish what we do. We've issued a series of white papers that arguably made us, person for person, the most transparent part of government, and that's exactly how it should be. We also publish academic articles. We have a ton in press, actually, that set out rigorously what we've done. And I think this is entirely right. It should be scrutinized if you have a higher profile. What about making sure that you aren't assuming people's true intentions? Well, one thing you could do is ask people what they think about a policy idea. I haven't seen much polling data, actually, so far at the conference about what people think. So this is from the UK. It's a survey that was done very recently by Ipsos Mori. It's available online. Just asking people, what do you think about some of these policies? You've got some there which are about reformulating food. You've got some about removing sweets and chocolate from checkouts, calorie information, public money from taxes being used to provide free fruit in schools, TV ads for junk food not to be shown before 9 o'clock. Supermarkets should not offer deals on sweets and chocolate. So I'm not going to make much comment on this, just to point out that it's worth asking people what they think about policies. But I think also polling makes it difficult to tease out what we really think about something, particularly in more complicated situations. If you just ask someone, you may not fully consider it. So if you take the flagship nudge of, if you like, auto-enrolling people into pensions. So this is data, again, from Ipsos Mori, from 24 different countries. It was done in 2012. They asked people, to what extent do you agree with this statement? Government should change the law so that everyone has to enroll in a pension scheme. And I think that's 63% agree with that. 50-odd% of people said government should not get involved in what people choose to save for retirement. And 36% agreed with both of them. Okay, now, I'm not, so I'm going to explain why I've mentioned this. So in the face of unclear preferences, the policy response should not necessarily be to step back entirely and say, we're not going to act, okay? Or refuse to act, or to ignore or assume intentions. Rather, and I've given this result not to say, people are really stupid or anything like that. I've given this result to say we need to think about things because we have responses to questions that make sense at different times. So I think there's real value in setting up, if you like, a national deliberative forum that allows people to get into the issues, to engage system 2, if you like, and come to a recommended position. And I'm not just suggesting this, that's exactly what happened with this policy around auto-enrollment. In the UK, there was a series of major public forums all around the country, which culminated in something called National Pensions Day, where I think over 1,000 people attended. And they talked through the issues about auto-enrolment. And at the end of it, they voted on what they wanted to be the policy, and that was adopted. And we're engaged in discussions about setting up similar events for other contested policy areas. To conclude, you could argue that just presenting examples where nudges allowed learning, You could argue that I've just presented examples of nudges that allowed learning and autonomy, but that doesn't mean that nudges cannot be manipulative. You may think that. And that makes entire logical sense. But I hope that the cumulative weight of these examples of how behavioural insights have been actually put into practice in the health field does count for something. And this is a debate we want to engage in. So I'm grateful for the opportunity to talk to you today. Thank you very much.
We have time for Q&A. Please.
I have a question which may put the two sides of libertarianism and paternalism to the test in the British context. You had a slide at the very beginning that showed that alcohol was one of the leading preventable causes of loss of life or loss of quality adjusted life. And my understanding, I could be wrong on this, but my understanding is in recent years there's been a liberalization in the availability of alcohol in Britain, so that therefore leading to alcoholism, and more, DALYs, attributable to it. So the libertarian thing, which is everybody should be able to drink, at least any adult ought to be able to drink any time, anywhere they want, seems to be in conflict with the goal of actually protecting the population health. Do I have that right?
So it's interesting because what's happened is the licensing laws have been restricted. So if you go to a pub, there is greater freedom for the person running the pub to open later. It's worth pointing out that in Scotland, they actually have gone kind of the other way, and you now can't buy alcohol after 10 p.m. in a shop. Okay, so there's a liberalisation and a contraction. Alcohol is an interesting policy area. You can see in this graph, it's the only thing that actually goes the other way in the axis as well. It appears to reduce some disability-adjusted life years as well. So it's an interesting area. Alcohol policy, you've got to, with any policy area, you've got to weigh up costs and benefits about different things. You've got to look at the evidence of how much harm it's causing. And you've got to look at what you can do to counter that. That's my basic answer, I'm afraid. Does that answer your question, or is there another point?
I understand that, and I guess the benefit of alcohol is the moderate amount of alcohol is reducing heart disease. My guess is keeping the pubs open later probably, on balance, produces more harm than benefits on this. My question is, how has the Westminster responded to this? Is the response that we're going to go with the libertarian side or go with the population health protection side?
I couldn't give you an overall answer on what the actual policy drift is there. So it's quite a contested area right now. I think we're still trying to work out what to do, and I don't speak on behalf of the government, basically, so I can't give you a full answer, I'm afraid.
So let me ask a question, take the moderator's privilege, which is about cross-cultural influences. And, so you're a consumer of the literature generated on this side of the pond, but you're putting it into practice on your side of the pond. And I'm kind of curious whether you think there's this... the question is whether British people are much more tolerant of old-fashioned paternalism and what that means for libertarian paternalism. And in particular, I'm curious in a sector-specific way, that given how collectivized the NHS is, given that you already have NICE and all these other people making these kinds of decisions, whether you think that influences the tenor of the debate and what you're able to do or not do.
I don't have the slide actually, but there is a very interesting slide from this report that Maury produced around different national attitudes to government involvement. I'll try and just find the slide because it's worth looking at the reference if you want. Yeah, it's the one at the bottom there. It's really interesting. So essentially they ask people from all over the world, to what extent do you think government should get involved in influencing people's lifestyles for health? And it won't surprise you to know the US is right down at the bottom. I think it was 12% said that was okay and 63% said it wasn't. And yeah, if you're right, so if you go up, you can see it. Most countries around the 30s, 30%, 35% saying it's right for government to get involved in influencing healthy lifestyles, and Britain's about 39%. There are clear national differences. So the logical conclusion would be, yes, it does make a difference.
Nicholson Price from the Petrie-Flom Center. It's exciting because it seems like you're from a place where these things that are so recent are actually being implemented, and you might have genuine experience in how they work rather than kind of theory about how they might work. So I think you've presented a relatively optimistic view, and I'm curious as to whether or not in what seems to be a broader experience, you've encountered major problems or flubs or failures or things that didn't work out at all the way they were supposed to, and if there are any of those kind of anecdata you'd be willing to share.
Things go wrong, definitely. So I think that's also just a case of trying to do things in the real world. Things in policy go wrong. I think one thing that we haven't done, I've talked about it, but we haven't really done it, is around the policymaking process. In a previous job, I did a big study in the policymaking process. There are lots of things that can be done, and you could argue that you'd have a bigger effect by looking at the actual process and structure of government. Pressures mean that we haven't looked at it enough. I think everyone would agree that. We could have done much more by turning it back on government. The pressure's always to go out and achieve a policy goal. Has there been that moment to look back at government? How could you make this whole thing better? And that's something I think we could have done more on. There are plenty of other things that, in terms of actually implementing stuff, it didn't work out. Departments running out of paper, for example. Not having enough paper to issue letters, which you spend a long time setting up something very specific, and then something happens, demands, and it all goes out the window, and that's a lot of wasted time, to be honest with you. That's happened a lot of times. Or you think you have data on something you don't, and you've wasted time. But you get through it, you try and learn that you don't try and make things too complicated, actually. That's a big mistake I think people make. Just try and get proof of principle to start with and then build on that.
Thanks for coming.
Thanks.
This might be more musings than question, but I think its trajectory is ultimately kind of interrogatory. You mentioned how it's important to poll people about how they perceive particular interventions. And somebody had mentioned yesterday that you could look at a lot of behavioral regulatory tools as maybe just people who want to regulate by any means necessary, just finding kind of a path of least resistance because people accept it. And I was just kind of thinking about that, and I see a division between kind of figuring out potential regulatory interventions using behavioral insights, whether those interventions are hard or soft. I see a division between kind of doing a good kind of regulatory technocratic job of that and of figuring out how to sell regulations to get them accepted by the public, which to me seems more kind of political. I guess to this extent, there's a question. If a team is doing both things at once, could those work at cross purposes? Could it affect the kind of credibility of the team or generate opposition that it's seen as both a political and an analytical kind of entity? Or do you have any kind of further musings?
I think I'm going to say something extremely obvious, which is that policymaking is innately has to be political to some level. You want that balance between political input and technocracy. And the art is where the balance lies, to be honest with you. I think quite often, there's a kind of different things we do. We might, for example, get involved further up the process, which is actually what's the shape of a policy. You know, how could we, you know, if we're going to make one decision or another, how would we structure it? Another thing we do is more further down the line where, because we can't do everything, obviously, something's been set at a high level, and then how do you make it work? You know, because this one big thing, which I haven't really mentioned enough, but we think is really important, which is policy tends to be made and then sort of just thrown over to some other people to deal with. And the behavioural analysis would suggest that the way in which you do things are far more important than people previously realised. And so what we've done quite often is really get down into the detail, into some perhaps far-flung bits of the government, and really work with this to see what difference we can make. And trialling it, crucially, so you can show it did make a difference. So there are almost two things going on there, and it requires a different approach for both of them, I would say.
Yasha Sagai, Johns Hopkins. Are reducing inequalities and at least not aggravating existing ones objectives that the Behavioral Insight team should pursue, whatever other objectives it pursues for improving policies? And if so, what are the steps it takes to do that in terms of designing and evaluating the policies it suggests?
So reducing health inequalities. I think, as I say before, that with any policy there are a mix of objectives. Health inequalities, for example, Public Health England, major priority health inequalities. So if we were working with them, we'd obviously pay a lot of attention to health inequalities. It's not so much that we would say in everything we do it must be health inequalities. You may be dealing with more specific questions like missed appointments or like prescription errors. I think it's an important thing, but this is where I get a bit technocratic. In a sense of saying, well, if that's what the political masters have said is important, then I would obviously support that. Sorry, it's a bit of a cop-out.
Hi, thank you for your talk, Kristen Underhill, Yale. I know that the UK has been a very congenial environment for evidence-based practice and the implementation of that philosophy to a lot of different domains. You mentioned trying to evaluate as many of these policy decisions as you can in randomized trials. I'm wondering, what is that process like in the UK? And what are some of the barriers and facilitators to implementing randomized controlled trials of these policies? And to the extent that they've been done, how have the results been taken up in practice?
I think, so I'm going to concentrate on the main technical barriers for doing randomized control trials because there are many of them. I think the reason we kind of want to promote randomized control trials is, yes, because they obviously have a lot of strengths, but also they had, I think, the reputation in government of being slow, expensive, difficult, very difficult to get the results quickly and just something that you put to one side. And we wanted to try to show that, in fact, they could be quick, cheap, give very quick feedback and be used to improve the functioning of government. And I think that's something that hadn't really been thought about before. So we would go into a more administrative or operational part of government and say, can we work out, you're sending out hundreds of thousands of letters, can we work out what's working, what isn't? And that's the reason we did that partly is because we wanted to show from the ground up, if you like, that this made a difference. And you don't go and do that by going in and saying, right, take the biggest, most controversial policy and let's randomize it. You go in and say, what's going on right now? What that we're not even thinking about enough? And how can we learn from it? And so some of the barriers, obviously, 80% of our work is around actually working with people, turning up, being polite, communicating what we're trying to do here, being personally persuasive. That's the hard stuff, and that's what takes a long time. The ideas are easy in comparison, and they don't take very long. But it's the fact you have to go over there and make sure everything's working, work out what's going to go wrong, and really get into the depths of how government operates. That requires a lot of effort, and there are simply things that can go wrong because you're not aware of them, and that's why I think you should keep it simple. In terms of have they been used? Absolutely. It's quite compelling evidence. You can show this is what you're doing, and this is your clear outcome, and this is how much it's improved. that was quite powerful for us. Without that, I think people would just go, none of this is real.
Anas Rabia, PhD in health policy here. Michael, thank you for coming and thank you for talking. I just wanted to challenge you a little bit about the potential impact that actually public policy using behavioural insights might have in health. And the argument I want to put to you is something like this, that as we find out more and more about how we might apply behavioural insights to influence the behaviour of people around choices that determine sort of lifestyle-dependent conditions that you talked about earlier, alcohol I think is a really good example, that actually the private sector, the commercial sector, who are looking to profit from unhealthy choices, are going to be able to move at a scale and a pace that in the public sector you're just not going to be able to match. As a result, you'll be outgunned, and you'll end up having to resort ultimately to good old-fashioned paternalism.
I think it depends on the policy issue. I think in the private sector, what's interesting, having spoken to people in the private sector who do this, we tend to think that they have amazing knowledge, amazing power. It's all sitting in a database somewhere, and that may be changing. And people talk about big data and so on, may be changing. But right now, I think private sector is much more opportunistic. Does it work? Does that work? Without thinking systematically about the actual drivers. So I think that's one advantage we might have by taking a more scientific approach. We can get better generalizability by actually doing this in a structured way rather than a purely opportunistic way. What I'd say is that with any policy, you have to look at how the environment you're operating in is changing. What I wouldn't want is as a policymaker is just to assume, be complacent that, yeah, this will work, and that you have to be aware of what else is going on there. But there are instances where you could perhaps find commonalities in terms of the private impetus and the public impetus are aligned. You might argue, for example, around diet and soft drinks. Who knows? So I don't think you should put that off the table entirely either.
Let's take the last question.
Rebecca, law student. So in the US, we have a lot of kind of built-in nudges to kind of like in cost sharing to decrease, say, the use of brand names compared to generics is one of the things we were talking about yesterday. So like say with Medicare Part D, the cost sharing is based on a set percentage of the drug costs. So if they choose the brand name, they're obviously paying more than if they choose the generic. But in the UK, where it's my understanding that there's less cost sharing overall, how do you sort of build in those same sort of incentives for, say, choosing the generic over the brand name? Is that something there's some sort of incentives built into NICE, or how exactly do you deal with those issues? I'm
going to take privilege to answer a slightly different question, which is, it was related though, I think. There's an interesting study which I came across recently, which is if you give people timely feedback, physicians, on the cost of blood tests, for example, there's evidence that this is just something you order because you have to order it. And it goes back to the conversations yesterday. Simply just saying the cost of it and how many ordered in the year has greatly reduced the number that ordered. I think there are things you can do in terms of feedback where the choices are available. I think your point's slightly different though about, is the choice available and so on. I think that gets into sort of NHS policy that I don't want to risk giving an inaccurate answer to, but I think the things you can do with feedback loops to reduce costs that aren't being used enough.
Please join me in thanking our speaker.